Greetings, ladies and gentlemen. My name is Syed Aswar Hassan, and my roll number is EP177051. My group number is 15, and we have received the topic of presentation is bipolar disorders, and I will be discussing the subtopic of bipolar disorders, that is cyclothymic disorders, with you. Since the rest of the topic and its parts have been discussed by my teammates previously, so the table of contents of my presentation is the classification of mood disorders, cyclothymia, the general description about it, the clinical evidences, the clinical evidences, and the causes, the diagnostic criteria, by a differential criteria by how we classify, how we differentiate the mood disorders 1, the mood disorders 2, the subtypes of mood disorders 2, the management of bipolar disorders, um, pharmacological therapies, alternate therapies, and the case study. So, the classification of mood disorders is really important because it is really complex, and this classification, um, the content that is written here, has different differential diagnosis. So, it's really important to understand the differential diagnosis of each of the cases. So, since this is the science of psychiatric, so the two major prevalent disorders in the world are the mood disorders type 1 and the mood disorders type 2. The mood disorders type 1 is known as the major depressive disorders, in which the patient undergoes depressions, a lot of depressions, and the type 2 in which the patient develops a bipolar disorder or a mania basically. So the type 2 disorder has further bifurcated into four different pathways, in amongst which is the bipolar disorder 1, bipolar disorder type 2, cyclothymic disorders, and the bipolar disorder not otherwise specified. And there are other classifications as well, in accordance to with the prevalence of the disease. So cyclothymia is also known as a hypomanic disorder, since it is a mild form of bipolar disorder. Uh, it is to be very clear that a mania is is something, an abnormally elevated feeling, or arousal that the patient exhibits in his activities. So hypomania is something lesser than that, and cyclothymia is hypomania. If I would give a synonym to cyclothymia, I would give, or it is basically given, hypomania. So it is a mental disorder which has fetal depressions, panic, and suicidal thoughts, and a lot more. I think we'll be discussing in subsequent slides with the DSM manual 5 criteria. So I'm just giving you the brief description about the cyclothymia here. It is that the patient has a mood disorder. Since it is similar to bipolar disorder, the types of other bipolar disorders, so the differential diagnosis is very necessary to classify or to distinguish both of these. So the one thing that is really important to differentiate them is the intensity and the duration of the disease. The clinical evidence that is about the is that the symptoms are present for at least 2 years and 1 year in children. So since cyclothymia is a mild form of disorders, so a patient can easily be transformed into the mood disorders 1 or to the mood disorders 2. So you see, the patient who is suffering from this disease, hypomania, he can, if not treated, he can be converted such symptoms and such disease into two different ways, or either it could transform that disease into the mood disorder one, that is a depressive one, that is far more worse than the bipolar disorder 2, and the other path is the mood disorder 2, that is a bipolar disorder. So if it is left untreated, the severity would proceed. So the depressive symptoms of cyclothymia is that if a person from cyclothymia jumps to depressive one, the bipolar, the mood disorder type 1. So what he will be facing is irritability, aggressiveness, weight loss, change in appetite, insomnia, lack of sleep, despondency. The manic symptoms of cyclothymia is grandiosity, extreme talking, excessive talking, racing thoughts, restlessness, argumentative, reckless, impudent, insanity will be there in him, such kind of things. So the causes, since the causes of cyclothymia are idiopathic, they are unknown. But the two main factors that has been seen is the genetic factors. It is said that the 80 to 90% of the cases is seen that uh, the ancestors were having the bipolar disorders, and it was given it, or it was carried from the ancestors to the successors. The second is the non-genetic factors that can be of can be of different kinds. So most of them is the head trauma, environmental factors, such as is the lack of sleep, the jet lag, that the sleep pattern or the biological pattern or the rhythm of your body doesn't matches with the environment, that can create some environmental stress on you. The nutritional factor is the deficiency of electrolytes, the deficiency of important minerals and important electrolytes that the brain requires to function properly, that can result in such uh, disorders. The psychosocial environment is important. Dysregulation of amino acids, since our brain has the inhibitory and exhibitory neurotransmitters, so any kind of dysregulation in them can cause it. Uh, the pituitary, hypothalamic pituitary thyroid glands, hyperthyroidism can, or the hypothyroidism can also be the main cause for this. And since it's not restricted to such to numbers, there are a lot of factors that have been discussed, but these are the major ones. So, according to the DSM Manual 5 criteria, I will, since my topic is about the cyclothymia, that is this one, hypomania, I will be discussing. But it's really important to understand the major depressive mania and the hypomania, since these three uh, uh, can be mixed when a doctor or when a healthcare professional is diagnosing the symptoms. So it is really important to understand three of these. So the major depressive one is that the person faces more than 2 weeks of depressed mood or loss of interest or pleasures, along with the other factor that is mentioned below, that is insomnia, decrease in appetite, and trust. This thing that is the first point is written is that greater than 2 week period of either depressed mood, loss of interest or pleasure in normal activities is the major root of diagnosis of major depressive ones. For the mania is that greater than 1 week period of normal and persistent elevated mood is there in patients. And for hypermania is that number of at least 4 days of abnormal and persistent elevated mood. So you see the difference in three of these, and this is the difference that can bring a differential diagnosis and leading to your rational therapy. So the management of bipolar disorders is to eliminate the mood episodes, minimize adverse effects, prevent the reoccurrence of depressions and the mood episodes, avoid the stress, and the things that we need to monitor when we are treating the patients and when we are uh, evaluating him is his mood episodes, his medication therapies, adherence, since we are giving him the drugs, or since there is probability that we can give him the drug such as antidepressants, which can give him adherence, and withdrawal to the drugs can lead to severe adverse effects. Suicidal attempts are common and must be really checked and must not left unchecked, otherwise symptoms can be worse and the therapy cannot be effective. So non-pharmacological therapies include the psychoeducation, that is the counseling is really important to build the atmosphere around the patient, and providing him the love is really important. Uh, Removing any sort of complexities, inferiorities or superiority will lead to quick recovery. Pharmacological therapy is that the mood elevators that we all know is the lithium can be given as first choice of therapy because it is approved by the FDA. The combination therapies can also be given with valproate, and the carbamazepines can be given. Antipsychotics can also be given, such as carbamazepines. Lamotrigine is approved for the maintenance therapy, and other antipsychotics, other uh, drugs that can be given as olanzapines, quetiapines. In the dose, olanzapine can be given in the dose of 1500 mgs, and the quetiapines can be given in 1500 mgs to the patients to treat the disorder. So alternate treatments that are reserved is the benzodiazepines, antidepressants. So this is a case study about a girl named Dolores whose father had left her mother, and her mother has got a nervous breakdown, and she was admitted to the mental hospital. Within this period, the lady, the girl Dolores, at the age of 13, was raped. So this created a lot of depression in him, and the fear and phobia in the society uh, plunged him to to this disorder. So she she attempted a suicide that was unsuccessful and was admitted to the mental institutions where she was given the therapy, but it couldn't work for her. And then she was married to an abusive man to whom her relations was not good. Well, and the stress and the fear keeps on building on her, and that leads to deterioration of his health. Since the one of the fear of Dolores was that she was gaining the weight, and she could not explain this to her friends and other members. So it was the state that she was living in, and she was depressed on this since her childhood and her adolescence was in different sections. Her parents, father leaving her mother having nervous breakdowns, she being raped. The only thing that she was facing was despondency. There is a hopelessness in her. So the diagnostic criteria, so it is diagnosed that she was facing hypomanic symptoms for at least 2 years, and there was no major depressive disorders for to her, and there was no schizoaffective disorders as well. The treatment that is being applied to Dolores is changing his lifestyle, his diet, and a good counseling and a good environment where she could stabilize her mood, and this would have to be highly regulated in order for her to follow it and actually make the changes. The cognitive therapy must be there, and the medications must be followed, such as the lamotrigines, the valproates, the quetiapines. The lithiums can give him a better mood elevations, and this non-pharmacological therapy must be maintained for months and for years to that she could gain faith again. Thank you.